session live from the Kenyatta International Convention Center. We are talking about the cancer burden, and earlier on Lucy had just highlighted a few issues there. She spoke about finances, the financial burden, the lack of counseling and lack of inclusivity when the policies are being addressed. But let me hear from one more cancer warrior before we come to the panelists for reactions. Yes, ma'am, start with your name kindly and tell us your story and what you see as the gaps. What would you like, where the areas of intervention?
My name is Sally Kwenda. I am a colon cancer survivor, but also a caregiver. And what motivated me to be a caregiver is what I went through as a patient. My first diagnosis was in 2007. And because I'm living with HIV, so I was exposed to the HPV virus, and I got cervical cancer and then colon cancer. I must say that I was privileged because at that moment I was employed and I had a very good insurance cover from my employer. And so I must say that after my contract ended, I realized that I was not able to take care of my hospital bills. And so if it happened at this moment, I think I wouldn't survive. Yeah. Because I'm even struggling to pay NHIF. So for me, I would say that if I borrow from a leaf from HIV world, we still don't have a proper system for cancer. For example, today we say someone wants to go for screening. Where do they go? And then what happens? Like now in the month of October, we'll find that there are so many people doing screening, but so what? After the screening, are we following up on these people? Where are they going? Another thing I would say is being a caregiver, I've realized that a lot of people are dying, not because they have cancer. I call these figures satanic figures. And I come back to Dr. Meli. NCI, will you also look at the cost? How much is a consultation for a doctor? I appreciate doctors have gone to school and college and they've studied medicine. I don't take it for granted. But the figures they charge, I call it satanic. And to be honest, as a caregiver, I've seen and watched patients die and stay in their houses because of the figures that the doctor said. Because you cannot bargain. A doctor tells you go and look for $1 million. You have no choice. You have to look for the $1 million. All right. You cannot bargain with the doctor. Another thing about community health promoters now, they were health volunteers before. I'm still thinking that we need to involve more of the survivors, cancer survivors. The ones who are existing, who are there, I think they were taken during the time of HIV. We need to involve cancer survivors. Okay. Somebody like me, I'm wearing a colostomy bag because of going through colon cancer. If I tell someone else that this is what I'm going through, they'll understand more than someone who's just learned about colostomy bag. You understand what I mean? Okay. Lucy, who doesn't have a breast, will interact more with a woman who has not gone for screening instead of somebody, Millicent, who has just gone to learn about screening, that please go and get screened. It is more effective if we involve someone who has gone through that. Okay. And I'd like to hear reactions from my audience, from my panelists here. And Omar, I'll start with you before we come to Dr. Meli, because there's a direct question for you there on this issue of lack of counseling and diagnosis, because Lucy had mentioned earlier on that they somehow missed it almost twice. And even when they discovered it, they were almost shocked themselves. They didn't consider taking her through the process and telling her this is what happens. As an untrained oncologist yourself, what is the right way of doing this?
Yeah, so that's a great question, and it's a common problem. It's a big problem, and in cancer diagnosis, we call it the continuum of cancer care. It's a process. It's not a one-stop shop. From screening to early detection to diagnosis to treatment to what we call palliative care, survivorship, and the whole continuum of care. Counseling should actually be added that, and it is added in the national guidelines around the world. In Kenya, we don't have a lot of let's say, oncology counselors. There are not many. They ought to be there. They should be part of the multidisciplinary care of cancer.
Even oncologists themselves are not making.
Even oncologists, most of the oncologists are not trained for counseling, because you're not supposed to. There's a lot of task shifting. We end up doing things that we're not really good at. We're trained to be very empathetic, of course, to listen more and enlighten the patient more about their diagnosis and their treatment pathway and the side effect of the treatment and the duration. We're not even trained to talk about even the cost. But what I like to do in my own practice, I incorporate the whole continuum of care. But I shouldn't be doing really counseling, because there are people who are more well-versed and well-trained. So oncology counselors really should be incorporated through probably training by the NCI or the NCCP or Ministry of Health. And it's really something that's a huge gap that needs to be filled. Okay.
Omar, I'd like you to talk about the issue of what Sally is calling satanic figures of dealing with this. Is there any way that counties can even come in and subsidize, or what have you done in Homa Bay yourself to ensure that the figures are not satanic, like Sally is saying?
Yeah, Sally, I'm sorry. I mean, the way she's expressed it, talks loud. It all boils down to finances. It all boils down to the financial capacity or capability of an individual or a community to get this cancer services. So in Homa Bay, we are trying to push for social insurance, the NHIF, because we believe that that is the only way we can sort out a community at large. So social insurance, we urge the public also to see into it, how can they as well get insurance. But earlier on I said that the very basic social insurance that we have, that is NHIF, we need to be involved. The communities need to be involved, at least to even talk about these packages. Because I said before that package for screening is not in that, it's not in the NHIF. But package for complex, expensive treatment of cancer care is there. So if you can revise it again and see into it, how can many people get screened as much as possible, as many as possible? Then at least we can prevent the progression of this disease. We can also encourage people to come for screening.
All right. Dr. Meli, on the issue of finances, and there was an issue of after the screening, then what? There's no follow-up.
All right. I always look at survivors as, you know, these are the results of the hard-earned efforts that everybody puts into to make sure that those who are diagnosed with cancer survive. And I hear you, Sally, I hear you, Lucy, on behalf of those who are not here, many of them, and there is hope. I think that's what we should have. 10 years ago, things were not like how it looks right now. 10 years ago, there wasn't so much available for a patient diagnosed with cancer in this country. But right now, there is so much that, you know, we can be proud of that the government, through Ministry of Health, through now, including even establishment of National Cancer Institute to coordinate everything, we are looking at patients who are able to present to the hospital and get care. The challenge here is information. And I think if there is, you know, an area that we need to improve is to create more public awareness so that people can know even what is in their next door. Sometimes patients do not even know that they can actually get services in, you know, the farthest of Kajiado County, in Turkana, because it is not always about the oncologist. It is always about our healthcare seeking behaviors as well. We have many primary healthcare physicians, including even clinical officers, who, if they are well trained and they pick a lump somewhere in Lokitang, in Turkana County, they should know if there is a lump, I should refer this patient to the nearest facility. So you talk about patient navigation. And again, the National Cancer Institute of Kenya is working on a digital patient navigation model. So we have identified that as a problem. And we are already curing it. And soon we're going to launch this model. And we are working with partners to make sure it's digitized. Today, in Kericho County, The Mashujaa Day celebrations are ongoing, and we are doing screening on site to demonstrate that it's possible. It is digitized. And when you get diagnosed with a lump, a mass, a lesion, you are tagged to a nearby facility where further investigations can be done, and then you will be in the system, and you will be able to access treatment through that entire system. So we are actually putting all efforts to make sure that the systems are working. The reason why we are refocusing, and the reason why NCI is now taking its strategic role, you know, with all the support that we have now from Ministry of Health, we are going to make sure that where, you know, rubber meets the road, things are done.
Okay.
On funding, again, if we've been aware on how NHIF is getting restructured, you will appreciate that the government has a very deliberate effort. As the president always says, not even a single Kenyan should not, you know, be denied access because they can't afford.
Yeah.
And that is why we are, you know, launching UHC on Friday during Mashujaa Day. If you look at Social Health Insurance Authority, that is now going to succeed NHIF. It has, you know, 3 pillars where we can really benefit. We have the Primary Healthcare Fund. This is going to address issues of screening. It will address issues of the community, primary healthcare issues. It will address, you know, public education and awareness. And I hear you that we should use people who have the experience to be community health promoters.
Yeah, the inclusivity part.
That is the inclusivity bit that you've mentioned. Point taken. We are going to make, you know, from time to time we review our interventions, and your voices will certainly be included. We are at the era of patient-centered, you know, care. If you look at many times we've been developing policies, yes, it has been, you know, top, bottom. But now, remember, we are in the bottom-up government. So we will take your voices and make sure we actually utilize them. We have Social Health Insurance Fund, which would be like the current NHIF. You will be contributing to it. It is going to cover for, you know, from screening. It will also cover diagnosis. I know there's been a challenge. There's been limitation in coverage for diagnosis, yet we cover treatment. Okay. We have had you and NHIF being sister saga under Ministry of Health, and we've had stakeholder engagements from time to time. They are aware, and now this will be included so that we don't pay for, you know, advanced disease, yet we could pay for screening and prevent. Okay. We also have chronic fund, which also is going to be administered by the authority. This one, if you exhaust your social health insurance fund, there's going to be a criteria on who will benefit from the chronic fund. And cancer is big in this. Okay. We will have someone, if you meet the criteria, it will top up so that you cannot spend. You know, UHC is about financial protection, to make sure that you're not going to sell your land anymore. You're not going to sell your animals to treat your loved one and end up in abject poverty because you don't have funds for school fees for your children, you don't have funds for food, you cannot even travel, you cannot afford even to travel to get care when you get simple malaria, and you end up dying because of that. So there is a deliberate effort to make sure, one, there is inclusivity. Yeah. Two, there is funding across the entire continuum of cancer care. We will continue championing for your interests. Okay. That is why we exist. Okay. I want to take 3 more reactions from the cancer warriors. But Omar, there's something that Lucy had mentioned earlier on when they were trying to diagnose her, and they somehow missed it. And we know, and also Dr. Meli had mentioned that more than 60 to 70% of diagnosis is at stage 3 and 4. So is this because the doctors don't know what they're dealing with, therefore there's misdiagnosis, or is it because of late diagnosis? What is the problem here? Yeah, I think I really hear Lucy's predicament. It's a common thing, and it's a problem that cannot be quantified at one stage. What happens is it's a very common knowledge in Kenya that a cancer patient, a potential cancer patient, gets to see at least a minimum of 4 or 3
doctors or let's say healthcare professionals before they end up being diagnosed.
And most of those 4 will misdiagnose.
Yes,
them.
yes.
Why?
So the issue is, I think, it's a structural trickle-down effect. We don't have a lot of professionals who are oncologists at the first stop of that patient. So we need more oncologists, as we are training more now, and the country really, now the ratio of a patient, cancer patient to an oncologist is really wide, let alone even the general doctor to a general disease ratio. So I blame it onto the problem of few oncologists, professionals, and also their access at a, let's say, grassroots level or at a county level. So at Garissa Cancer Center, we're privileged every Monday. The patient comes to the clinic straight away, and we are there as consultant physician and oncologists to take over. They've been worked up the week before by our team, the clinical officers who also have a higher national diploma in oncology. They have medical officers which we trained on what to order, which test to order, and then within 5 days we get to see them. But that's a privilege in the centers that have oncologists. So we really need to take more oncologists into
capacity
mashinani.
building. Okay. All right. Let me hear from yes, ma'am. I'll take the 3. The lady here, and then the gentleman there, and the one at the back. Yes, go ahead.
Thank you so much, Trevor. I'm Millicent Kagonga. I'm a cervical cancer survivor, and I'm also the face of cervical cancer prevention, my daughter being the first one to be vaccinated. My journey started at the age of 20 when I started having the abnormal discharge, and I went to the first facility, but I was told I'm too young to have cervical cancer. But first I kept quiet because I didn't have the information about cervical.
You're too young to have cancer.
Yes, yes. The first facility, and I can't mention it, and I went to another facility and I insisted to be done for the screening, cervical cancer screening, and it came out positive. That was 5 years later, and after the diagnosis, I was told to go and do some more tests, and I didn't have money. Like Sally said, that is like satanic figures. As like you said, 47,000, we are losing 47,000 people to cancer. And let me tell you the truth, we are not losing 47,000, we are losing more. Because how many can afford 45 to 50,000 Kenyan shillings to go and do the biopsy? Because the biopsy test is the ones that confirms that this person has cancer. But we are losing more people because they don't have the 45 to 50,000 cash money, because NHIF doesn't pay for that. So we are losing more.
Okay.
And then we need to work on that gap. If maybe, like Dr. Melly said, I'm just assuming that the UHC is going to be paying for the diagnosis, which is very, very, very important. And I want to thank Dr. Abdi for talking about the research. And I want to mention that we need to do more research in the place called Dandora, because that side we found out, like, even 3 members of the family, we have losing 3 members from one family because of cancer, and nobody is talking about that, and nothing has been ever said. So in Millicent research, I'm trying to convince myself maybe it's because of the dam site, but I don't know.
Okay.
And then another reaction I want to react about Dr. Melly saying about quality care. I need to breathe in, because the other thing that I'm doing, when I was getting, I got my treatment at KNH, and when I was getting my treatment there, I used to sleep at the corridors. When Citizen TV had the story in 2017 about ladies sleeping at the corridors, I was among them. And I can tell you the truth. I am the only one, or maybe 2 of us, survived from those corridors. And most of them didn't die because of cancer. They lose the battle because of pneumonia. They lose their battles because of the stigma. They lose their battles because at night we were forced to get out of that place because we are not supposed to be there. I believe we have good doctors here in Kenya, and the doctors are doing a good job. I really appreciate, because if it is not true about the doctors here in Kenya, I don't know if I could be alive and I could be a voice that I'm having like right now. Okay. But the challenge, we are not on the table. We want the survivors to start from the policy makers to the doctors. We want the survivors to be there when the information you are being to be told, like you have cancer.
Okay.
And about the quality care again, can I shock you, Trevor? Can I tell you last week, a patient alikwama kwa machine ya radiotherapy at the facility. How many machines do we have at Kenyatta Hospital? How many? We have machines, but they're not working. Like right now, the counties wamepewa machines. So that queue yenye iko pale, it's not supposed to be there. How can you tell a patient to atoke Kenyatta aende to a private facility ambayo NHIF itatoa pesa mingi kwa kadi ndi apate dawa? Have you seen a prostate cancer patient akiwa amekosa dawa yenye anameza kila siku? I run an organization with more than 300 patients, cancer survivors. I've seen a man breaking down for the lack of drug yenye anafaa kumeza on a daily basis. But the last minute anaambiwa go to that facility, a private facility, upewe dawa. Have you seen that, such cases? I've seen it. I do accommodation at Kariobangi, free accommodation, because of what I went through. And there comes my question. I understand there was a time to Liskia, we are having a hostel at Kenyatta. How far is that?
Okay.
How far is that hostel?
All right.
The final one.
Yeah.
To Dr. I think Dr. Okumu. You have talked about other cancers. What are you doing about vulvar and penile cancer in Homa Bay County? Among the patients when you accommodate, they are coming from that area, and vulvar and penile cancer has a lot of stigma.
Okay.
A lot of stigma. What are we doing about that?
Okay.
That's why it is very, very important for us to be on the table.
Okay. Thank you, Millicent. And you've heard the questions, so I'll come to that in just a bit. Yes, sir. Start with your name, please.
Thank you, Trevor. My name is Peter Nyete. I'm a caregiver, trauma counselor from Amani Counseling Center and Training Institute. And I'm concerned about the mental health in cancer care. I've come across many cases of persons who don't know that there's psychosocial support for cancer care or any other life-limiting illnesses. People will always say, I wish I knew that these services exist. My loved one would not have passed away. Others, maybe even who have been misdiagnosed. I know of a case of somebody, a lady who was misdiagnosed for breast cancer and a mastectomy was done. Then later it's discovered it was not cancer even at all. And then she's just left that way. I mean, so I'm wondering, are there any policy interventions to ensure that psychosocial support is offered, particularly at the time of diagnosis? And what is being done to ensure that primary oncology providers at least have some basic training in counseling?
Okay.
Thank you.
Thank you, sir. Yes, sir.
Okay. Thank you, Mr.
Use the microphone, please.
Thank you for this opportunity that you've given me. My name is Sami Asiko. I'm an esophageal cancer survivor. My biggest concern comes from in terms of job. As you know, cancer treatment destroys both the good and the bad cell. It does not choose the good or the bad. So as a man, first of all, your immunity goes down. So the life after cancer becomes different from other fellow human beings, the normal ones.
Okay.
So in terms of job, I don't know what the government or someone can assist me to tell me which steps that they followed that can assist.
Yeah.
Because we found it very difficult.
Okay.
In terms of hours of working, and in terms of the type of job that you are being given.
Okay.
Thank you.
All right. Yes, I see there's quite a number of you. I'm not sure we'll manage to get through all of them. But the back line there, yes, we haven't had anyone there speak. Yes, go ahead, sir.
Thank you, Trevor. Thank you, all the panelists. My name is Samuel Buru, an MSc reader and national one. And also, I've been affected because the elephant in the house is either you are infected, you are affected. So mine is on 3 perspectives. One, the economic perspective in regard to NHIF. The issue of topping up. Imagine you transist a patient from Muranga, and then he or she has been referred to Kenyatta or KU referral. The same NHIF card has been used to clear the bill at the point of referral. But now at the destination in the referral center, he or she has been told to top up maybe extra 2 years or 3 years. Nikiongea kwa lugha ya Kiswahili hapo hivyo. Kama huyo mtu angekuwa na the 12K, kwa nini angetoka Muranga akuje KU ama akuje Kenyatta? Sio the 12K angetumia tu penye yako. I recommend. Okay. And in this regard, first we appreciate ile kazi mzuri inafanywa na national government because our president akona ile the bottoms up approach. Congress, our president and the entire team. Lakini kuna few gaps somewhere. Hii mambo ya topping up. In relation to kama the leader mama venye inafanyikanga. I'm sure wamama wetu wakati wanajifungua. Kama if you don't have a valid NHIF, you have been entitled to register for a leader mama na inakuwaga active instantly. Can the same model be used to our brothers and sisters wale wako na hii cancer, ati ukienda hata kama huna NHIF, you only been registered na inakuwa active instantly. Okay. 2, viability and affordability. Tunaweza kuwa we have the good infrastructures in place, good supportive systems, lakini inakuwa ni yetu sisi mtu wa kawaida. Okay. But for the elected category, all waheshimiwa, wakati wanapatwa na hii janga, wanachukua ndege wanaenda wapi? Kwa nini pia wao wasiwe kielelezo chema ati anaweza tumia facility ya KU ama Kenyatta ndiyo shida yake ishe? Okay. Lastly, awareness. Okay. Wakati mmoja wetu, because we are all candidates to be cancer ama any condition, wakati mmoja wetu anapata accident, anakufa kwa barabara, during the year pale hivi chini kuna kumeandikwa the cause of death. Fulani alipata accident at a certain point. Sivyo? So, the congregants wamejua mwenye wanakuja kuzika, wanamzika cause of the accident. Bona hii jaga ya cancer. Kwa hiyo the same paragraph yoro hapo chini kusiandikwe mmoja wetu tunazika leo, tunamzika kwa sababu ya nini? Cancer. Ya cancer. Okay. All right. The more tunaiogelea, the more hata the awareness inakuwa hali ya juu.
All right. Thanks, Samuel. Millicent, please pass the microphone to the young lady in the front there. Yes.
Hi, so my name is Cecilia Wanjiru. I'm a thymoma cancer survivor. So I'm going to talk about the childhood and teenage cancer, where I don't hear people talking about it, and we are the most affected ones. Because I got my cancer when I was 16, adolescent stage, where I told, when I explained to the doctors, they told me that it's just adolescence, I'm just maturing. So it was so difficult for me until they diagnosed I had cancer at Kenyatta. I had a cancer. I had an accident at Valley Road. That's when I was diagnosed, because I went at Kikuyu. They told me it's just I'm maturing because I'm a lady, breast and everything. So I'm gonna say that we are suffering from mental illness, and having mental illness, the people we are referred to as counselors, they are not people who are experienced what us we are going through. Okay, so I'm gonna be referred to a counselor. She hasn't or he hasn't experienced about cancer, and and being a teenage, they always know that we always fake things. So being faking things, they always tell that even our sickness we are just faking. They said everything is all right, but everything is not all right. I tried suicide for 3 times. 3 times I was in the hospital because of trying suicide, because when I go to the psychiatrist, they don't help me with anything. So I just want to address about we are suffering from mental illness, mostly. Yeah, right. And also financially. I have ever slept at a hospital. I won't say which hospital, because my dad lacked 500 shillings to see the doctor. And it was at night, and I had asthma, and also my chest was paining. So we have to consider about the people who are going to be cancelled about, and also the financial problems. Okay, thank you.
Thank you, Cecilia. Thank you for being strong enough to talk about that. Yes, I'll take the last one there, ma'am.
Hello, my name is Sarah Wangoi. I'm on active treatment right now. And what I would like to ask my doctors here, why are we having too much reoccurrence in breast cancer? You have not talked about it. And like for me, I was diagnosed 80 years ago, 2015, but I have done 4 surgery, the same breast. What did you do? You are going to do now? Because for now, I'm in chemotherapy. I've done first line, I've done second line, 6 chemo, and now I'm doing another chemo, which I don't know what is it, but they are doing chemo. I'm in 5th section. My hair has gone, my nails, even the feet, they are all black. I want to know, what have you been doing all this while? Of all these surgeries, nimefanywa surgeries 4 on the same breast. I'm wondering, na bado uvimbe zinaendelea kutoka hadi saa niko na mauvimbe, ndio kwa maana nimewekwa kwa chemotherapy. Thank you.
Okay. Wow. These are very touching stories. I am pressed for time, but because these are very touching stories, we have to give you a chance to speak. Yes, sir. I'll start with you over there.
Okay. My name is Kariuki Kimwere, and Cecilia is my daughter. And we started a community-based organization called Childhood and Teenage Cancer Initiative to try and address what these teenage and children go through, because that was our experience. Cancer, we knew it when my daughter had the accident there at Valley Road. And we never knew that children can get cancer until she got it. Saa zingine ulikuwa naenda kwa daktari anakuambia huyu mtoto pengine hataki kwenda shule. That's why ana behave. She's in pain. But daktari anakuambia hapana, huyu she's maybe pretending, maybe anataka skips a lesson ama 2. So it's kind of doctors have understand that even when tumekuwa na hii discussion, there's no doctor amekuja amesema, even our panelists there, hakuna mtu amekuja akasema this is how we want to treat children, ama this is how we are treating children cancers. In fact, these cancers they are very common. Hata kuuliza mtu yote anakuambia prostate cancer, hiyo ingine breast cancer, for adult cancers, but the children cancers are there. She had in our team, she has lost around 2 or 3 children ambao wako na cancer. So I think it's better ikuwe addressed sana on the children cancers, and maybe you should give us maybe a way of addressing the children cancer, and the teenage cancers zitoke from the adult cancers.
Okay. Yes, sir.
Thank you so much. My name is Paul Kariuki. I am a caregiver, lost my mother to cancer. I'm now involved in advocacy. Thank you so much to Citizen TV for this opportunity. The role of the media could not be overemphasized. We hope to see more even across the rest of the months. 2 questions. Cancer registries. Where are we? Where do we want to be? What are we doing about it? And perhaps Dr. Meli could add, the digitization of the navigation system Could we include a component for recording, for the reporting of incidences? And this one, I'm not requiring any response, but is it about time we started thinking about rationalizing cancer treatment given the cost, so that we say we don't have to treat everything. Okay. Let's see what we can do. Thanks.
Right. Thanks, Paul. I think we'll still have to fit in 2 more. This is, yes.
Hi, my name is Joan Wangari. I'm a pancreatic cancer survivor.
Joan?
Joan.
Okay.
From 2011. So my question is, I want to ask the doctor, I have not had a lot being talked about pancreatic, yet it is one of the deadliest type of cancer, and it is affecting people, and people are just dying, because when you are diagnosed, when it is advanced, people die immediately after that. Second, my question is about Disability Act. We are not recognized, like most of us. I underwent surgery and chemotherapy. I lost part of my body, part of my pancreas was removed, and also spleen was removed. We have other patients who have lost both. You can see maybe they have lost cervix and maybe ovaries, but they are not recognized because it is not a physical disability. They only recognize the physical one, and yet we are affected. We cannot do our day-to-day activity. What are you going to do about it? Thank you.
Okay. Thank you. The last one. Yes, sir.
My name is Peter Okoth from Fadhili Cancer Support Organization. We focus on awareness, prevention, and research. So my question goes to Dr. Meli. We have HPV vaccine that is kindly somehow being rejected by the community. So how are we going to ensure and work together that we spread awareness and ensure that the community understands the importance of this, so that it can be taken? Because we go places, we talk about it, and we don't have answers to give them. So we need to work on our system, also to do a lot of research about the DNA of the African gene compared to the Europe and all that, so that the cancer treatment can be effective to us and to the entire world.
Thank you. HPV vaccine has actually been a success in Homa Bay, so I'll let Okomo talk about it. But Omar, let me start with you on this issue. There's quite a number of issues that have been raised. Millicent spoke about biopsy charges being 45 to 50,000, something that people can't afford. Sarah spoke about too much reoccurrence, that now she's about to go through more chemotherapy. What are you going to do so differently now that you didn't do 80 years ago? So what is the problem there? Start with those two.
Yeah, so Millicent, Millicent, right?
Yes.
Sarah. I'm sorry. Sarah's predicament is quite common, and she deserves an explanation. So what happens is, in the cancer care world, we say treatment of 50% of cancer treatment is information. If you didn't know that, now you know. That is a huge statement. 50% of cancer treatment is information. People are talking about chemotherapy. Why? Because that sits on that algorithm. Once patient is informed, they're enlightened, they're empowered. The treatment compliance, goes up, survival goes up. The other reason why information is very key is it really honors the patient as a decision partner. Like you make decisions together, not a one-way sort of a partner and relationship from doctor. Do this, you're stage 4, the counseling part is not there, you're bombed with all this information which is very hard to digest, and you're told, come tomorrow for chemo. That's not the right way to do this thing. So anyway, for the issue of recurrence, it's a multifaceted thing. It could be let me not talk about why that is common. Let me talk about what we can do about that. What we can do about that is every case, according to the international guidelines of cancer treatment, should be discussed in a multidisciplinary manner. So if it is an early stage, let's say breast cancer, yes, the most common treatment is to remove it because it does not spread anywhere, but the surgeon cannot just unanimously do that by himself. We need to sit with the oncologist, the surgeon, the counselors, the pharmacist, the nutritionist, palliative care services, and even in some parts of the world, the imam or the rabbi or the pastor for emotional healing and acceptance. So I think the part where the disconnect is information to the patient. Yeah. If she knew what she has at the first point of care, that she has been told you have, let's say, breast cancer, you have stage 1, this is how we treat it, you might be different because of how your cancer cells are behaving, or you might respond to this kind of treatment, we would like to try this. an informed decision and not overhyped hope.
Yeah.
Okay.
So does cancer treatment really work?
So I know that is a question that really it's on the mind of many people. If cancer, okay, the mantra around the world is if cancer is detected early, it's treatable and even potentially curable. But when you present at stage 4 or 3 due to either systemic failure, healthcare systems are not strengthened, patient empowerment and healthcare seeking behavior, or even cost of early screening being really exorbitant, people don't even want to know. And the cultural part of cancer as a stigma, people don't want to find out that I don't even want to go to the doctor because he might tell me I have cancer. Or I don't want to do this scan because I might end up being told I have cancer. We have a lot of terminal anxiety is one of them. People don't want scans because the doctor might find something. So cancer treatment does work.
Yeah.
It's not witchcraft, there's science behind it. But its success and its failure depends on patient and caregivers working together, and patients and patient being told what they have in lay language. Don't talk about how the cells are mutating and changing to a patient. Tell them you have this is how we treat it, and we think it might have not spread, and this is how we want to treat it, and this is what you should expect.
Yeah.
That way, will you accept it? It should be bidirectional and a mutual decision making to even start the treatment.
So as oncologists, are you just winging this thing? You really don't know how it works. You're just trying to figure out whether this will work or not. So you tell a patient that this might work, it might not work. Well, because Sarah is saying she's done this since 2015.
Yes. So since 2015, we don't guess. There are guidelines that guide us according to the stage of the patient and the type of tumor they have. This is well documented. And that's why doctors or oncologists don't work in silos. We work together. So whenever we're discussing, we have something called multidisciplinary tumor board. Where a case is presented, and Mrs. So-and-so, age this, came with a lump in her breast, staging CT showed that she has an early stage. What is the best treatment for her? Meaning here, the most acceptable to her culturally, the most effective according to the data available scientifically, and the least cheap for her, and the least toxic for her body. This is what we choose. We don't just say, the book might say this, might say the guidelines, sometimes it might not, translate to the patient in front of you.
Okay.
Yes.
All right, let me bring in Dr. Okomo on this. I know there's quite a number of questions for Dr. Meli. And Dr. Okomo, you can talk about the issue of HPV vaccine, because I know this has been a success in Homa Bay, and there was an issue that was raised about it, and also childhood and teenage cancer.
Yeah, thank you very much, Tim. We appreciate all the sentiments. And when I mentioned the 5 top cancers in Homa Bay, the list is long. I couldn't exhaust it. I only mentioned the top 5. Penile, vulva are also among them. And in Homa Bay, vulva has always been mistaken for female genital schistosomiasis. But it's among the list that I would have mentioned if I was given the opportunity to mention all of them. We also experience child and teenage cancers. And sorry that we didn't mention it, because here we were talking cancer in general, but we appreciate and accept what you've just shared with us. And sorry for the mistreatment. I think that one should not happen in this country. And I think it should also form part of the guidelines when we look at the psychosocial aspect of a teenager. And I think those are some of the areas that should be noted and put clearly, so that we don't mistake a cancer for someone who is in her teenage. Then I think something has been asked about HPV.
Yeah.
I think what he asks is that the success rates are not that good. It's not only in Homa Bay. It's cutting across the whole of this country. In as much as I know Homa Bay is doing a little bit better than the national aggregate at 38%, the national aggregate is 25%. Actually, Homa Bay 38.8, national aggregate is 25. This is a vaccine that is given to 9 to 14 years old. These are people who are still in school. And a 9-year-old to 14-year-old, these are still people who still need consent from the parents. So
I look at HPV vaccine administration as a complex issue. In as much as health we are pushing or we are trying to advocate for it, these people in the other side of the divide, they're in the education system. That's where the majority of them are. So unless we sit down and agree with the Minister of Education and even talk to the parents to consent that their children should be given the HPV vaccine, then I think we will win this game. Then the other thing that the public should know, and we should assist each other, when new antigens are introduced in this country, there is always a lot of hullabaloo, myths and misconceptions. And this one interferes with the administration of the vaccine. I don't want to mention what happens before, but we are really struggling as the health department and the Minister of Health at large to ensure that HPV vaccine, at least we reach the 95% herd immunity for our girls, our young girls. Remember, there are 2 doses that are supposed to be given.
Yeah.
If the first dose, Kenya nationwide, we're at 25%. The second dose, we're almost at 19%. We're normally around 25. So it means we still have a long way to go. We still need to have candid conversations with the parents, with the schools, because the healthcare workers have tried even going for outreaches in these schools, but they hit the roadblocks.
Okay.
So I think this is one of the cheapest way of preventing cervical cancer.
Okay.
But we need to also know that production of vaccines is very expensive, and vaccines also have timelines. So it's be given there by the country. The country has bought the vaccines. So I'm urging the parents, let's get out of those misconceptions and myths. Okay. The vaccine works, and it protects. It gives the immunity against human papillomavirus. So let's see how we can advocate. Media, please help us, our political teams, so that each and every child gets this vaccine. Then, of course, we're not going to have those numbers of cervical cancer.
Okay. Dr. Millie, there's quite a number of questions that came through to you. Millicent spoke about the issues of radiotherapy, some machines being faulty in certain places. Can you have research in specific areas? Peter spoke about mental health and policy intervention for psychosocial support. Sami was talking about jobs for people who are somehow incapacitated by cancer. Is it possible to have that? Samuel was speaking about the economic perspectives and the issues of affordability and awareness. Cecilia was speaking about childhood cancer. It's quite a number, but I'd like to, because you're the policy guy here, so I'd like you to keep talking about them, and if you forget one, I'll mention it back to you.
Well, thank you, thank you. This has been great. And I really appreciate opportunity to listen from survivors and family, and I treat this as public participation. A lot of the concerns that you've raised, we're going to look into them in detail. And for you to appreciate that the National Cancer Institute of Kenya cares about you, on Wednesday, the day after tomorrow, we have invited all the civil society organizations where most of you are in, so that we can have a conversation with you. More than 100 civil society organizations. We're going to meet, we're going to listen to you, you will be on the table, and we are going to consider your input in all the decisions that we're going to make. Many questions have been raised, and I want to begin from Sarah's question, why there are so many recurrences. I know Dr. Omar has, mentioned more about it. There are patient-related factors, and there are also tumor-related factors, and there are also system-related factors. System-related factors, looking at including the quality of even the drugs that you are receiving, including, the human resource, the doctors who are treating you. I must mention that our focus is, before you present to an oncologist, you need to have been seen by a very, very qualified clinical officer, qualified medical officer, qualified surgeon, physician. and our training curriculums in our institution so that we do not miss. You don't have to go to many different doctors before you are diagnosed. Like you are dismissed at some point. If a doctor dismisses you that you are too young to be diagnosed with this cancer, we see cancer even in one-day-old babies, in neonates. And I must mention that in our recently launched National Cancer Control Strategy, there is a whole huge chapter on childhood cancer. So Cecilia, have hope that finally the voices of the children is being considered in our sector, and there is going to be a lot of attention into it. The issues of winning the battle against cancer begins with children, because we are vaccinating children, literally. And if you look at, I always sensitize everyone that children are not the smaller version of adults. They have to be treated specifically. They are very delicate. They have, a lot of treatment. And a lot of childhood cancers actually can be treated so easily. The leading childhood cancer in this country is leukemias. We have kidney cancers for children called Wilms tumor. We have cancers of the brain. They are on the rise. All right? We have thymoma is one of cancers of the lymphoid system. We call them lymphomas. And these are cancers that can be treated. I have worked in a hospital where we have seen the success of children who die 100% when diagnosed with leukemia. Right now, we have 60% cure rates. So it is actually possible that we can treat adults, including children, and your voices are heard. I look at the many questions that have been asked here being work that I'm going to sit in my office and see how to address individual issue, Trevor. Yeah. Mental health is a big thing. Sorry, Cecilia, that you had to attempt suicide 3 times. There are many actually who have succeeded. I've had a patient who in the morning was walking, but in the evening slept and never woke up. Depression is real. And the challenges that you are going through as, a cancer specialist who's treated patients and now sitting at policy, sitting at leadership, looking at all the governance issues in cancer care, I do understand that at the policy level, there is so much that we need to do. We need to capture this as a real issue, and it's part of treatment. We have a lot of, we work, we don't work in silos, we work in collaboration. I know we have Mathare National Hospital, which is the leading hospital in the country in taking care of mental health, but ideally, all our hospitals, and we are going to begin this specifically, Trevor, to even begin training programs for counselors. Yeah. Lately we have been innovative to create local programs which are specifically addressing a particular issue. And we have to, and when you present to a doctor, when you present to a counselor and you feel, I wasted my time, I didn't get value for my, resources, it is really sad. And as I've mentioned, you must have value for your investment. And we will work so hard from the National Cancer Institute of Kenya to make sure that you get that value. You've talked about quality of machines. It is true, radiotherapy machines, to be very specific, they are cost intense, they are capital intense. They occasionally, get into technical challenges. And that is why at Kenyatta National Hospital, where they have only one machine, in public, it's only Moi Teaching and Referral Hospital that has 2 machines. We are sensitizing, and part of our advisory to Ministry of Health is every public facility should have at least 2 machines so that in case one gets a technical hitch, we can use the other alternative machines. And this is work in progress. And I do understand, I know I was in this country treating patients when patients slept in the corridors of KNH. They do that in Coast General. I have had concerns from my colleagues who work in these centers. In Moiti, every of these regional centers, there is traffic. And people who do not budget for where they'll spend the night to be reviewed by the doctor the following day, and they end up staying a whole week when they never planned, because you are sent to go for an investigation, you are asked to come back, and the idea of hostels is alive. It is what we are discussing with these individual institutions. We are looking into the, maintenance contracts for machines to make sure that they are able to have more than 90%, uptime to treat our patients, so that you are guaranteed of this quality. I do believe in quality. And for a long time, we've had policies that are not translating into service, connecting policy and service delivery. That is why NCI comes in between as the implementing agency, so that the policies can then be implemented at the point where there is service delivery. And there is continuous monitoring and evaluation, there's continuous feedback, and we are going to be talking to the institutions. We've had a lot of stakeholder engagements because we've identified where the challenges are, and we're going to follow up. And we are trusting with the support that we are receiving, and that we will be asking that a lot of the challenges we are mentioning here today, we may not promise that we will address them within a day, but we've heard you. We will consult with everyone, both state and non-state actors. Yeah. If you look at, even in this country, we've had partners that have really supported to improve the quality of our doctors. 1 month ago, we had AstraZeneca had a preceptorship program to train our specialists on how to diagnose and treat prostate cancer. And because the experience and the equipment is limited in our country, they had to sponsor more than 30 doctors to go to Cairo University to be trained for 1 week through a preceptorship program, so that they can get the requisite skills that we do not have here. And they are now going to donate some equipment through a program called Cancer Care Africa, to 7 of our regional centers, so that the doctors who had been trained can use this equipment for proper diagnosis and for proper treatment. But generally, we are talking about training for all healthcare workers, not specifically an oncologist like myself or Dr. Hamid, who we are also treating patients after being diagnosed with cancer. So there are many issues that you have raised. I may not have responded to others, but I have my team here. We have taken into consideration, and let us continue engaging. Okay. That is why NCI is there. You can reach us through our website, you can write to us, you can call us, we will be available. If you have a challenge, if you go to hospital and you have a problem, we will be happy to reach out on your behalf, so that your concerns can be addressed.
Okay. We are really pressed for time here, but there was a question around the issue of physical disability, this being recognized as physical disability. Yeah. It marries to what Sami was also talking about, jobs for that.
That is really important. If you look at the Cancer Prevention and Control Act, and I want to sensitize us to be looking at the laws that have been enacted in this country. It protects you. If you look at this act that established National Cancer Institute of Kenya, there is so much that has been detailed. There should not be any discrimination of anybody who is diagnosed with cancer. And if you feel discriminated at your workplace, please feel free to reach out to us. If you feel discriminated in school, reach out to us, and we can advocate for you, and we are going to ask for your right. If you are being overworked, yet you have lost, probably due to complication of treatment, you've lost probably sensation. There are people who, you mentioned you had nasopharyngeal cancer, some people lose hearing because of treatment, and someone may dismiss you from work because they think you are not productive. It is your right. No one ever chooses to be diagnosed with cancer. Unfortunately, it occurs like an accident. So if you have disabilities, I know issues to do with fertility. I know you mentioned about ovaries being removed, uterus, and then these hormonal issues affects your working in general. It may not look like someone who had cancer of the bone and they chopped off the leg. People have brain tumors, and courtesy of surgeries, you end up having, loss of function of one hand, one leg, And you have people who have prostate surgeries being done, and they get urine incontinence. Sally has mentioned she has a colostomy, and she's happy to talk about it so that the rest, other people can be encouraged. These are all considered actually as disabilities. And because we have offices that deals with disability in our, institutions in general, this is something that we will also advocate for you.
Okay.
We will take it seriously and look at even opportunities for work for someone who is diagnosed with cancer.
All right, thank you, Dr. It's almost midnight, and this was an important conversation, and I want to thank you all for having the courage to share your stories. You are the real cancer warriors. I think you all deserve a round of applause for being brave enough to even speak about this on national TV. I'm sure you've encouraged someone back there at home. Dr. Elias Meli, CEO, National Cancer Institute of Kenya, thank you so much for making time. Dr. Gordon Okumu, County Director of Health, Homa Bay County, and also the Chairman, County Directors of Health Forum, Asante Sana, and Dr. Omar Abdihamid, Clinical Oncologist and Garissa Regional Cancer Center. Thank you very much for making time, and thank you all for being brave enough to share with us right here on the Monday Report, as the media will definitely give more platform for conversations like this one. Okay, this is the Monday Report. Special thanks to the Kenyatta International Convention Center for hosting us tonight. Bye for now.